Welcome to today's PHO Rounds, titled Bridging Hepatitis C Care Gaps, a Modeling Approach to Achieving the World Health Organization's Hepatitis C Elimination Targets in Ontario, Canada. My name is Austin Zygmunt, and I'm one of the public health physicians at Public Health Ontario, and I will be moderating today's session. And now it's my pleasure to introduce the three speakers for today's session. The first is Yeva Sahakyan, is a scientific associate at the University Health Network in Toronto. And her areas of expertise include health economic evaluation, decision modeling, and statistical analyses. Her current research focuses on economic evaluation of infectious diseases such as chronic hepatitis C and COVID-19. Our second speaker is Beate Sander, who holds a Tier 1 Canada Research Chair in Economics of Infectious Diseases and is a senior scientist at University Health Network, where she chairs the Collaborative Center for Health Systems and Policy Research. Dr. Sander is an internationally recognized leader in infectious disease economics with extensive experience in health economics and simulation modeling. And our third speaker is HongAnh Tu, health economist at Ontario Health, with extensive experience conducting health technology assessments to inform funding decisions. She brings a strong background in economic modeling, including cost effectiveness and budget impact analyses across a range of critical areas. And so I'll now hand it over to our presenters to begin their presentation.
Thanks so much, Austin. I'll get started on behalf of all three of us. And so we will be tag teaming through the topics, kind of first discussing a more academic exercise and modeling and economic evaluation, looking at what combination of interventions would enable us to achieve WHO hepatitis C elimination goals. And then HongAnh will speak to how this work was picked up and expanded on and used for policy decision making. Next slide, please. Before we start, I would like to acknowledge that the University Health Network operates on the traditional territory of many nations. That includes the Mississaugas of the Credit, Anishinaabeg, Chippewa, and the Haudenosaunee, and the Wendat peoples. And it's now home to many diverse First Nations, Inuit, and Métis people from across Turtle Island. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. We would like to encourage our team, our colleagues, and partners to take time to learn about the lands they are currently on and action these learnings. We stand with all Indigenous people, past and present, in promoting the wise stewardship of the lands on which we live. Thank you. Just the disclaimer. And next slide, please. Just to kind of go through the learning objectives for today as well. So learning objectives are to identify key strategies for scaling up hepatitis C services in Ontario to meet WHO's hepatitis C elimination goals, to discuss the timelines and feasibility of achieving those goals, to assess the cost effectiveness of presented strategies, and then finally to describe how the modeling techniques or modeling itself and economic evaluations support OHTAC's funding recommendations in Ontario and guide policy decisions. All right, let's start with the academic work that myself and Yeva will be tag teaming through this part. Okay, so chronic hepatitis C is a significant burden. It affects about 55 million individuals worldwide. It can lead to life-threatening complications that includes liver cirrhosis, hepatocellular carcinoma, and liver failure and transplantation. Chronic hepatitis C is responsible for about 290,000 liver-related deaths each year. And also Canadian estimates from 2019, which kind of indicate that there are about 200,000 people living with chronic hepatitis C infection in Canada, and almost 2,700 hepatitis C related deaths were reported also in 2019 in Canada. Here, just have an overview of the DAAs, or direct acting antivirals, which is was a relatively new treatment. It's been around for a while now. It has substantial cure rates of 95%. It also has a more favorable safety profiles compared to the older drugs. And so with the AAs or direct acting antivirals, there is an opportunity to eliminate hepatitis C as a public health concern. And so what you can see in the figure is based that's work from Mina Tartarus, kind of looking at prescribing pattern over time and by different providers. So the black line on top is the total, and then we are looking at different providers. And we have like the different kind of policy decisions there at the A, B, C in terms of expanding the AA coverage, which initially was covered only through a prior authorization program. Then in 2017, that listing was expanded for DAAs, for all DAAs as a limited use product. And then as of 2018, newer DAAs were added and the kind of disease-specific criteria were removed. Next slide. And so just to kind of familiarize everyone with the WHO's 2030 HCV global elimination goals, they are to reduce new infections by 90%, to diagnose 90% of people living with hepatitis C, to initiate treatment for 80% of people who are living with hepatitis C, and to reduce the mortality by 65% compared to 2015 levels. Next slide. What does this mean in the Canadian context? So Canada is committed to Hep C elimination. And so what that includes means to identify any gaps along the hepatitis C virus care cascade. So from diagnosis to linkage to care to treatment and cure. We have an Ontario roadmap, which also calls for intensified testing and treatment scale-up, so kind of broader than a risk-based screening. However, Ontario has been lagging behind in hepatitis C elimination, and I'd say that's already kind of during COVID-19 pandemic, which kind of now missing the right word, which kind of also has had an impact on our progress and in terms of hepatitis C elimination. Sorry, next slide. And so with this, we come to the objective of our study, which was to identify the level of service scale-up and investments that are needed along the hepatitis C care cascade to achieve WHO's elimination goals by 2030 in Ontario, Canada. Now I'll be handing over to Yeva, who'll be speaking on the methods.
Yeah, so thank you, Beate, and I will proceed with the method. Okay. So we conducted cost-utility analysis using a decision model and compared hepatitis C diagnosis and treatment scale-up strategies versus status quo in Ontario. The key outcomes included mortality, quality-adjusted life years, and health system cost. And we ran the model to 2030 to see if scaling up could achieve WHO's elimination target, in particular a 65% reduction in liver-related mortality. This is a state transition model which explicitly accounts for two key components: hepatitis C care cascade and disease severity. Ontario population was stratified into uninfected and infected individuals distributed across care cascade. Uninfected individuals could either remain uninfected or become infected and either clear the virus or develop chronic hepatitis C. Individuals with chronic hepatitis C in the model can either remain undiagnosed or proceed through care cascade and be diagnosed, receive treatment, achieve viral clearance, or become disengaged from care. The second component of the model focused on disease severity, moving through fibrosis stages F0 or no fibrosis to F4, which is cirrhosis. From cirrhosis, people could progress to advanced liver disease that includes decompensated cirrhosis, liver cancer, and liver transplant. And only individuals at these advanced stages were considered at risk of liver-related mortality, the primary outcome that we were trying to estimate. We also assumed in the model that people who achieved cure at earlier stages would stop progressing, while those who cured at cirrhosis stage or at more advanced stage could still progress but at reduced rate. To inform our model, we used evidence from several studies based on Ontario Health Administrative datasets. And I would like to highlight that this work was only possible because of linkage between Public Health Ontario laboratory data and ICES administrative datasets. Our first source of ICES study that estimated hepatitis C prevalence in Ontario, including the proportion of undiagnosed cases. This study used annual incidence of advanced liver disease events to back calculate the prevalence of chronic hepatitis C. Our second source was another ICES study that described how people are distributed across hepatitis C care cascade. The third ICES study we used provide estimates for healthcare costs across different stages of the disease. And finally, health utilities, as well as transition probabilities between the states, were relied on published systematic review and meta-analysis. So this is what about our model inputs. Now about the strategies that we modeled. We first set up status quo strategy, which reflected current practice in Ontario using two-step diagnosis with antibody and RNA testing and current treatment uptake. From that back calculation study I mentioned earlier, we took antibody testing rates, which ranged from 4 to 13% depending on birth cohort. And of those who tested positive, we assumed that 88% would undergo RNA testing and only about 53% of those who tested positive on RNA would receive treatment, and which reflects the estimates from the care cascade study. Next, we compared two alternative strategies designed to meet the WHO's target of a 65% reduction in liver mortality by 2030 relative to 2015 levels. The first alternative was an improved linkage to care strategy, which we can hypothesize to be a reflex texting, where we increased RNA testing and treatment uptake to 98%. We did this incrementally, step by step, to see if the target could be reached, and if so, what level of scale-up would be necessary. If not, we added a third strategy, reaching undiagnosed population by doubling antibody testing rate. And finally, if goals still weren't met, we extended time horizon, asking if not by 2030, then when would the target actually be achieved? And while we had estimates on the downstream healthcare cost of testing and cost of antiviral, we didn't know what it would actually cost to operate the program. Therefore, we took a reverse cost effectiveness approach and estimated the maximum amount the program could cost and still be considered cost effective using $50,000 per colleague threshold. And now I will pass back to Beate to continue with the results.
Thanks so much, Yeva. And we can move on to the next slide, please. Okay, so big question is, do the strategies meet our WHO targets? And so in the figure, you can see the kind of proportion of the population that will be diagnosed, treated. And for mortality, it's a reduction in mortality. So that's kind of how remember how the WHO targets are kind of formulated. And so we are showing this for the three different strategies, the status quo, then improved linkage to care, and then the third one, improved linkage to care plus increase in antibody testing or screening program. And so with the status quo, or with none of the programs, let's say we would reach WHO targets except for treatment by 2030. So that's true for our status quo, where we were projected that 72% of individuals would be diagnosed before developing advanced liver disease. And where 43% would receive treatment before developing advanced liver disease, and where we would see no meaningful reduction in mortality rates compared to the 2015 level. So that were the gray bars. Now, if we improve linkage to care, for example, like with reflex testing and linkage to treatment, that would be the red bars. We would diagnose 70% of people with chronic hepatitis C and treat 75%. So it's some increase. However, we are still falling short of WHO goals with respect to mortality. And then basically improving linkage to care and adding, in addition to that, screening to reach the undiagnosed population. So those are the blue bars here. We found that 85% of the population would be diagnosed, 83% treated, and we would reduce liver-related mortality by 57%. So still falling short of our goals. And so now we add 2035, so basically extending our timelines to reach WHO targets. And so now with the combined strategy, basically, again, improving linkage to care as well as having reaching the undiagnosed population by specific screening programs, we could reach WHO targets for mortality, for treatment, not quite yet, so for diagnosis. Okay, so next slide. So now we're kind of talking about cost effectiveness. So in this figure, we're looking on the horizontal axis at incremental quality adjusted life years gained. So what that means in comparison to our status quo, how much do we improve or how many extra quality adjusted life years do we gain per person in our 100,000 population that we modeled. And just a quick reminder that quality adjusted life years are an outcome measures that combines morbidity and mortality, where basically we assess quality of life on a scale from 0 to 1. So if someone is sick, then it would be less than 1 quality of life. If there's mortality, then those life years would be entirely lost, obviously. So we can combine all this into one outcome measure. So here we are looking at incremental or additional quality adjusted life years per person compared to the status quo. And then on the vertical axis, we are looking at incremental cost, again, compared to the status quo. So the round circles or dots are for our 2030 time horizon. And so you can see that compared to status quo, what we just explained, we have better health outcomes. So basically a higher proportion diagnosed and treated and fewer people and decreased mortality results in improved quality adjusted life years. And so we would even increase that further if we have the combined strategy. So not only improving linkage to care, but also trying to reach the undiagnosed population. And then if we increase our time horizon, we follow up to 2035, then we even move further to the right on our horizontal axis. So we are gaining even more health. Now, in terms of cost, that's a very interesting thing that you see here already that I think HongAnh will come back to. So if we look at the 2030 time horizon, you see that even with just increasing or improving linkage to care, there is a very little additional cost. A little hard to see, it's just above zero, but there is a higher cost with the additional screening. And the reason for that is that obviously there are, as we improve screening, if we improve diagnosis and linkage to care, so we have expenses by testing and by providing VAAs and treatment to patients that are not offset really in that very short time horizon. But then as we move further, like into 2035, that's when we kind of realize all that benefit of preventing all those downstream events. And so in terms of cost effectiveness, so what Yeva mentioned already, we are looking at how much could we spend in a program for these type of interventions to still be cost effective. And so here we are looking at the 2030 and 2035. So if we look at the 2030 time horizon, our program could be considered cost effective at that 50,000 per quality adjusted life year threshold. So that's what we would consider a good value for money. If it costs a maximum of 852,000, so that is for the improved linkage to care program. And that's also, and we could spend even more in this particular program if we expand it to 2035, because then we realize all the cost savings of those kind of long-term liver-related sequelae or complications. And if we extend the time horizon, then adding increased antibody screening would also be cost effective, and we could have quite substantial amounts invested into this type of programs. So what we're showing you here is per 100,000 people, but if we would scale it up for the Ontario population, then instead of 852,000, that would translate to 12 million in annual cost, or the 1 million invested if we take the 2035 time horizon would translate into 27 million. And it could be invested in this type of programs and still be cost effective. And so again, like in the model, we already included kind of the testing and treatment. So these would be special efforts made, for example, to reach undiagnosed population groups, to have specific tailored programs and special effort made to link people to care, to have them tested, etc. Next slide, please, Yeva. Thank you. And so we also looked at the different birth cohorts. So overall, I think for most of the programs and the 2 time horizons, you'd say these interventions are cost effective, not so much in the 1945 and earlier cohort where kind of the broad antibody screening is not cost effective, and it's mostly because at the 1945 and prior birth cohort, it's people who would be 80 years already now, so there is not much time to generate that benefit. Okay, next slide. So I think some limitations that we want to talk about our modeling assumptions, like very important is that we used a static cohort. So basically what that means is that we did not account for immigration patterns. And that's why we would frame the 2035 analysis specifically. So the longer out we go, the more important it becomes that we use that static cohort, because we are not bringing in basically new people who may have hepatitis B infected already with hepatitis C. On the other hand, we also kind of cut off our model at those time horizons. So there are still people who would generate the benefit of the treatment they had, but we don't account for it because it happens after 2030 or after 2035. We only included a one-time screening option, and so there was no repeated testing for high-risk populations in our model. And we did not evaluate specifically any other type of intervention. So any specific tailored interventions or any further upstream interventions like harm reduction services or anything that's aimed at prevention. And so in terms of policy implications, what we found was kind of the challenge, of course, is to reach WHO's 2030 targets, and they would be unlikely to be met under our current infrastructure. And I think we knew that already. And so extending the timeline to 2035 or maybe even a little further would be more realistic. In terms of strategic focus, from our perspective, it seems that we would want to streamline care through reflex RNA testing and also think about point of care diagnosis and treatment. So kind of minimizing the number of appointments people need, and so that they're linked to care very efficiently. And of course, that there's tailored outreach and expanded screening to reach the undiagnosed populations, where there be a greater benefit overall. And then finally, our modeling would support, or our analysis would support, strategic resource allocation into hepatitis C elimination. And as you will hear, like it was contributing, this work contributed to inform evidence-based decisions for Ontario's hepatitis C strategy. And that's something that HongAnh will be speaking to in the next slide. So thank you so much from Yeva and me, and I'll be handing it over to HongAnh.
Thank you so much, Beate and Yeva, for your presentation. And I am HongAnh too. I'm the health economist from Ontario Health, and I'm going to present how OHTAC make funding recommendations and giving the hepatitis C screening as an example. This is a disclosure. I have no conflict of interest. So this is an overview of the presentation for my section. There are two parts. The first one, I would give an overview of the health technology assessment. Second one, I would go into the process and methodology of conducting HTA, giving hepatitis C screening as an example. So what is HTA? Health technology assessment, or HTA, is a structured process used to evaluate the clinical effectiveness, cost effectiveness, and broader impact of healthcare services, treatment, and technologies. It helps ensure the decision about publicly funded healthcare services that are evidence-based and align with the needs of the populations. So why the HTA matters? So HTA have to ensure that limited healthcare resources are used wisely, supporting evidence-based decision-making on technology adoptions in Ontario. The hepatitis C screening project is a great example of HTA in actions. We review the clinical evidence, economic evidence, and patient preferences, and value evidence to help determine whether a new approach to screening or treatment should be publicly funded in Ontario, considering both clinical outcomes and system-level impacts. This slide summarizes all types of the technologies that we assessed in Ontario Health. And you can see the hepatitis C screening belong to laboratory tests. So who we are? I am from the HTA program in Ontario Health. Our team support Ontario Health in making recommendations to the Ministry of Health about which health technology should be publicly funded. And you can see that there's 5 stages of the process for HTA. Currently, the hepatitis C screening HTA, it just live for public comment yesterday. We are receiving the comments from the public. And after that, at the end of the October OHTAC, we present the responses to the public comments before OHTAC make final recommendations. Now I'm going into detail of the example of the hepatitis C screening HTA. So we received a request from the Ministry of Health, as mentioned by Beate, that Ministry of Health plan to achieve the elimination of HCV as a public health threat in Ontario by the year 2023. So at the moment, the current risk-based approach is the screening is currently used in Ontario. However, the ministry wanted to look at the option of expanding HCV screening approach to either all adults or to people born between 1945 and 1975, in addition to risk-based screening in Ontario. Before conducting the HTA, we did a lot of consultation with different experts in Ministry of Health, in Public Health Ontario, in hepatitis C working group, and also with the clinicians and health economists in academia. So what evidence we consider before publicly funding? So there's 4 types of the evidence that we consider. And in this presentation, I'm particularly go into the economic evidence. So part of the economic evidence, we conducted primary economic evaluations. Here we try to answer the questions of what is the cost effectiveness of one-time HCV screening plus risk-based screening compared to risk-based screening alone for 2 different populations. Number 1 is all adults, and the second is the birth cohort born in 1945 and 1975. So as I mentioned, as Yeva has mentioned about her models, so we adopted the model developed by Yeva with some of the modification that highlight in red color. So we particularly investigate 2 populations. One is individual of 18 years older in Ontario, and the second one is the cohort born between 1945 and 1975. We also updated the cost of different testing like antibody testing and RNA testing to the most updated cost. In terms of the time horizon, instead of using the 12-year time horizon as mentioned by Yeva and Beate, we extended the time horizon to lifetime to see the benefits that hepatitis C screening can bring. And also we extended the willingness to pay not just to 50,000 per quality, but also to 100,000 per quality, because for OHTAC, we don't have a defined cost effectiveness threshold. I also want to mention a little bit more that we are very grateful that we received data from the Public Health Ontario laboratories, in which that it helped us to calculate the probability of people who receive antibody testing and RNA among people who have the disease and with no disease. In terms of the results, so for reference case analysis, if screening for all adults in addition to the risk-based screening would be less costly and more effective than risk-based screening alone. In other words, screening for all adults would be a cost-saving or dominant strategy. We also look at the cascade of care outcomes for 100,000 people to be screened. You can also see that with screening of all adults would reduce number of decompensated cirrhosis, liver cancer, liver transplant, and liver-related deaths. We see the similar result in screening for the birth cohort born in between 1945 and 1975. So screening of this particular cohort, in addition to risk-based screening, also less costly and more effective than risk-based screening alone, or in other words, it would be a cost-saving or dominant strategy. And we also see that, screening this birth cohort, in addition to risk-based screening, also reduce number of decompensated cirrhosis, liver cancer, liver transplant, and liver death. Part of the economic evidence analysis, we also conducted budget impact analysis to estimate the 5-year budget that the Ministry of Health in Ontario would need if they would like to consider funding one-time hepatitis screening, in addition risk-based screening for the two populations I just mentioned. So for the reference case analysis, if the government consider to publicly funding all adults in Ontario, it would require 22 million in year 1, or 14 million in year 5, or for a total of 111 million in 5 years. We go beyond to see just 5-year budget that need for the government. We want to see and explore when the hepatitis screening for all adults would become cost saving for the Ontario province. As you can see that, in the blue line, that is a cumulative BIA, and on the yellow line bar, it's the yearly BIA. So in the year 16, when the cumulative BIA become negative, which shows that the screening of all adults in Ontario would bring saving of becoming a cost-saving strategy for the government. Similarly, for the budget impact for the, if just the government consider publicly funding for this birth cohort, so it would require 9 million in year 1, 1 million in year 5, for a total of 32 million in 5 years. So when the screening for the birth cohort between 1945 and 1975 would be cost saving. So we do, again, this exercise, and it shows that cumulative BIA would become negative, as you can see on the slide. And it means that beginning from 13 years, the year 13, this strategy would be cost saving for the government. At the moment, the funding recommendation is the HTA is available for public posting. However, OHTAC on the website is also OHTAC making the funded recommendation that HCV screening is recommended to fund for all adults in Ontario government. And we also have a key message to take home. So we can use that model-based recommendation that, should streamline care to maybe using reflex RNA testing to get access, to make people can get access to treatment timely. We also can consider point of care testing, as mentioned by Beate, to streamline the resources and everything can happen in one appointment. Modeling support strategies, also talking about the allocations. So in terms of the OHTAC analysis, so screening for all adults or for both cohort screening, in addition to risk-based screening, would be a dominant strategy, or less costly or more effective than risk-based screening alone. 5-year budget impact. So if funding for all adults in the Ontario, it will require 111 million in the next 5 years. If only consider public funding only the birth cohort, 1945 and 1975 birth cohort, it would require 32 million. And thank you.
Okay, so I want to thank our speakers for their insightful presentation today, and we will move into the question and answer period. So if you've not yet put your questions into the Q&A, you can see that at the bottom of your screen. Before maybe we get started with some questions, it's an opportunity to highlight some work that Public Health Ontario has done with some of the strategic focuses that were noted during the presentation. So our laboratory is streamlining some hepatitis C care by expanding RNA viral load reflex testing, and that was done last year to cover individuals who had a previously reactive HCV antibody, but no record of an RNA test, as well as those with a first-time inconclusive HCV antibody test. And as was noted during the presentation, this improvements to RNA reflex testing can really simplify the testing process for patients with hepatitis C, reduce their recall for follow-up, and also help healthcare providers connect their patients with Hep C to care sooner. So we do have a few questions in the chat, and so I think the first question is for our first presenters around what was included in their models, and so there's a question around hepatitis C reinfection, and is that something that you considered in the model?
Yeah, I can answer that question. So indeed, I didn't present that part, but we included the reinfections in the model. It was modeled for low-risk population, the risk of reinfection, and the people who were reinfected were entering a model as undiagnosed individuals, and then they were proceeding through care cascade the way they were originally modeled to proceed, and they are entering to the same fibrosis stage when they were at the time of SVR, at the time of treatment. So their fibrosis would continue to progress from the moment they were treated and then reinfected. I hope I answered the question. If there is any further clarification needed, happy to.
Thanks, Yeva. The second question, I think it's an easy one for you, HongAnh, is just how people can provide public comment on the HTA that Ontario Health has done. So I know you've noted that the public posting is open, and if you can share a link to that public posting in the chat, that would be great. Some of the attendees would like to provide their input.
Definitely. So so yesterday we already posted. You can go on the Ontario Health website and search for hepatitis C HTA, and we can see that there will be the public like comments, like required for the public comments. But I also later on can put the link in the chat after the presentations end, yeah, so that you can get access directly to the HTA and also the recommendation by OHTAC, and where you can send your comments and review the report, the original report that we have done. Yeah, thank you.
Maybe just a quick follow-up on that. How long do people have to provide that feedback on the HTA?
Yes, very good question. So I forgot to mention. So you got until October 13th. So basically 3 weeks for provide the questions. And during that period, when we get any question from the public, our team, including health economists, clinical epidemiologists, and patient engagement specialists, we would take comments and we respond. We will bring back to OHTAC in October, end of October, to address the comment before OHTAC make final recommendations. So October 13 is a deadline. Yeah.
Thank you. So the next question is around another part of the models. Did you specify the timing of screening in the model?
Is this a question for me or for Yeva?
I think probably mostly for you, HongAnh, because we didn't have that kind of one, screen everyone kind of strategy. So I think it's more
Okay,
for
so
you. Yeah.
sorry, yeah. So as I mentioned earlier, so we adopted the model from Yeva. So all of the features and parameters is the same, which is updated. Some of the parameters, but the model, the time horizon of the model is a lifetime horizon. Yeah.
Actually, I think I can answer. Sorry, Austin, you're going to read the question.
Yes, I think it'll help. It's similar to this, I think. So the next question is looking at why cost effectiveness is improving over longer time horizons, and now seen in both. So could speak to that a little bit.
Thanks so much. I can get started, and HongAnh and Yeva, please feel free to jump in. And thanks, Kevin, for that question, because I think it's something very typical we see in public health, where we have an upfront intervention, so kind of the screening, diagnosis, treatment, and the benefits of those interventions are down the road. So there is a time element between most of the costs that are more upfront and the benefits that are kind of a bit delayed. And so that's why as we increase the time horizon, then we accumulate all that benefit. And so that would make it more cost effective. As if we only follow up for 5 years, maybe people would not have yet had enough time to develop long-term complications from hepatitis C infection. So we don't really account for that benefit. So that's what you see with those longer time horizons. I think the other thing I just want to mention, because HongAnh did talk about a lifetime time horizon. So for this type of interventions, it's also really important to consider it's really 2 time horizons. So one is kind of at the program level. And so that's what was the focus for our analysis, because we really wanted to see what combination of interventions along the cascade of care would enable us to reach WHO goals. And so going into that, we kind of naively, or at least I very naively kind of thought, oh, maybe we, have some combinations of increasing diagnosis, linkage to care, treatment, that would enable us to reach those goals. It turned out we wouldn't be able to do that just by increasing linkage to care and RNA testing. So we needed to go further upstream in order to reach those outcomes. But then you actually also really need to follow for a longer time until you see those outcomes. And so the second time horizon is really at an individual level. So for each cohort that was screened in 2025, that's screened or treated 2026, 27, and so on, each cohort we could follow until the end of their life. And so making sure we account for all those benefits. And so that's what HongAnh was related to. And I don't know if you want to jump in, HongAnh and Yeva.
Yeah, I can speak a little bit about the lifetime model. Or when we extended the model at a longer term, we will see more benefits or even cost saving. So, for example, with this particular projects or HCV screening, so you can see that maybe the overall population level benefits of screening is small. However, screening would enable early diagnosis and also treatment, as mentioned already, that when we have the linkage to care faster, better, which will prevent the high cost associated with managing advanced stage liver disease. So this is one of the things that, and then also that, even though that, we screen patients, it entails really high upfront costs, but it is a cost effective long-term strategy, because, the prevention of long-term morbidity associated with the untreated HCV, and the treatment cost for the disease is really expensive. So you will see that for the long term, the impact of the screening would generate slowly and gradually when the model is extended for a longer term. Yeah, so that's what I wanted to mention. Yeah.
Okay, well, there's a few questions in the chat that are questions for PHO, so I'm happy to take a stab at some of these and welcome others' thoughts if you have any. So one question is, how do newer technologies like point of care tests, which we now have for hepatitis C, impact our case definitions for confirmed cases in Ontario and for public health case and contact management purposes? So those case definitions are set by the Ministry of Health with input from Public Health Ontario, and a positive point of care test at this time would not meet criteria for a confirmed case. And so those individuals who are having a positive point of care test would be recommended to have follow-up serology to confirm their diagnosis. And then there's also a question in the chat about how the screening recommendation might impact other types of recommendations for hepatitis C testing. And so the examples provided is if someone has an exposure to a bloodborne pathogen like hepatitis C during IPAC labs investigations, they get tested for those bloodborne pathogens, so HIV, hepatitis B, and hepatitis C. So I think those are two separate things. So I think the screening recommendations for Ontario would be separate from the recommendations for someone who would have an IPAC exposure. And I think those individuals would still be recommended to be tested after their exposure, regardless if they've been screened in the past for hepatitis C. So that's it for questions in the chat. If there's none other in the next minute or so, I think we could end this session early. Is there any other items our speakers would like to say that hasn't come through the discussion period today?
Not much, but yeah, I've noticed about timing of antibody testing, and then it was reiterated as a age-based exposure of this antibody testing. Yes, we applied not age-based, but birth cohort estimate for the antibody testing. So each of the birth cohort, those were born before 1945, from 1945 to 65, and after 65, they had different antibody testing rates.
Okay, we've had one more question come into the chat. So this is a follow-up to the question that was just answered around the benefits of longer durations for the model. So is there any additional benefits in terms of reduced transmission?
The model didn't account for that because we were applying like constant infection rate across the years. And as also Beate mentioned, it was just a closed population, not a dynamic population. It was no immigrations, nothing was accounted, and only the stable constant infection rate was applied. And moreover, people after 50 years old or something like that were assumed have no transmission, which was based on the no infection, no probability of having infection, which was also based on the literature.
Yeah, no, just adding, like, thanks so much for that question, Kevin. Like, so absolutely, you would think that transmission would be impacted if we diagnose more people and treat more people. But I think at the kind of broad population level, I'd say, so in that sense, our analysis would be considered conservative because we didn't capture that additional benefit. I think it would be really important when we talk about specific population groups and kind of maybe more talk about micro-elimination goals and strategies than kind of this very broad, sweeping population-based measures. Thanks.
Can we have some follow-up comments around the screening recommendation and how that impacts IPAC lapse testing, and I think I might be misunderstanding the question, so can follow up with that individual who's providing the comments in the chat. I think if you were to be exposed through an IPAC lapse, you would still be recommended to be tested for hepatitis C, regardless if you've been screened for hepatitis C in the past, but I might be misinterpreting what they're trying to get across. And so I think that is it. We will wrap up today's PHO round sessions. I want to thank our three presenters, Yeva, Beate, and HongAnh, for presenting today. And I want to thank everyone who joined us for today's event. You can expect to receive a brief anonymous survey for today's session. So if you can try to complete that, that helps to improve our programming, and have a wonderful rest of your day today. Thank you.